Why did you choose locum tenens?
I'm a hematologist oncologist. I trained at Brown University in Rhode Island. I did all of my training there, internal medicine residency, chief year, fellowship. I graduated in 2020 and I ended up taking about a year with my family. I ended up doing contract work straight out, basically straight out of fellowship, for a number of reasons. I like the idea of flexibility before trying a job before I got too committed. And the offer was originally, I said, okay, I'll commit to one weekend. That was the level of commitment I was interested in at first. It ended up being a great experience. And then I committed to more, and I still work with that group from time to time. But I think the flexibility is initially what drew me to it. The other jobs that I was looking at involved non-competes or promises for very long periods of time or financial commitments, taking out loans. But contract work ended up being a very good fit for me based on my lifestyle, my interest in clinical medicine, my flexibility. It gave me that flexibility to be with my family. And it's grown quite a bit from that one weekend. I can't remember, at least 120, maybe 130, worked 130 days last year. So I'm now very clinically busy, and it's been a wonderful thing for me.
What is the best way to find locum tenens jobs?
Word of mouth personal referrals is definitely part of it. I think I, at this point, keep up my contacts across my specialty. There's different social media avenues of finding out where people have needs, whether Facebook groups, LinkedIn, a friend of a friend, HemOnc groups, women's physicians groups, mom physician groups. Those are all a wealth of information about who needs what at what time. And then, of course, there's good old Google Maps. You can just see who's in that spot. And I do now have like a standard introductory email. This is my name. This is where I have my licenses. This is what I have done. If you need coverage here and here, please let me know. I'm available. And then set your expectations accordingly, because cold calling people has mixed success.
Please tell us about the demand for hematology oncology locums physician.
That's a good question. So you have to remember, I've I'm in my third year doing this, but I wasn't. I was able to work a bit around COVID because I was still in fellowship during the beginning of COVID. I've had different troubles. I've had troubles with locums agencies ghosting me. I've periodically had difficulty finding jobs locally in Florida. Florida is not necessarily the greatest market for oncology locums for various reasons. So sometimes I do have to travel further, but the further you travel, the more options you have. I do find that the demand is there. I am part of a group, a WhatsApp group of locums, HemOnc Locums, probably 80 or 90 of us. And so I think the rates are probably changing. I think I don't know how the recent events with Optum Health are going to change the need for locums in general, or especially oncology locums, because I think, as I understand it, and I'm a few years in, but I'm still somewhat newer at this. But as I understand it, oncology, the business of oncology relies heavily on insurance company reimbursements. It's very different than, say, direct primary care. So we'll see how things go in the future. But I think certainly the rates have been impressive compared to what I've seen in other specialties. And I don't feel like I've really had any difficulty negotiating what, has been offered.
How would you describe a typical HemOnc locum tenens assignment?
It's a mix. I think in Florida, where I've worked, I've seen a lot of more demand for inpatient roles. So in my role, I cover consults at the hospital. I think inpatient consult coverage is one of the easier ways that people can envision a locums, like a contractor working, being able to step in and step out cleanly, because a lot of oncology work involves these long extended relationships with patients. And so you have to have very good communication skills to be able to walk into a clinic setting where somebody has that relationship with their oncologist. You have to be able to walk in and say, oh no, I've reviewed your case. I know what's going on. I looked at your imaging. I looked at your pathology. I read your past oncologist notes. You have to really establish that rapport. So I think more inpatient work is what I've seen in Florida. But I've done both. Inpatients, I cover consults. I've covered between 1 and 4 hospitals. It depends where you are and how big the hospital is and what the demand is. For more involved gigs, I'll have either a resident locally, there's a resident that works with me, or APP support. And like I said, these consults tend to be more hematology based. So things like thrombocytopenia, anemia, clot workup, or like hematologic disorders of pregnancy, a lot of iron deficiency anemia. Somehow that makes very solid part of my consult list. And then, like I said, I think outpatient, I do get more requests for outpatient work, especially in, other states. And it's usually a mix of new and old patients. I think usually they try to start you with a lower number of patients to begin with. And I've noticed that as compared with, say, other specialties, they do tend to start you with lower patient numbers, which kind of makes sense when oncology is also a specialty where there's a lot of coordination. So you have to coordinate with, the radiation oncologist, you have to coordinate with whoever's doing the biopsy, you have to coordinate with the surgeon, you have to, coordinate with, there's a lot of different moving parts in that regard. And sometimes it's every single visit. You have to look at their CAT scan and so on. So usually those patient numbers are not particularly high. And I think the other thing is, so when you have a no-show rate, when you only have whatever, anywhere from 8 to maybe 14, 18 patients, and your no-show rate happens, then it's very variable how many patients you'll see in a clinic day. These have all been in community-based settings, although I have entertained working for academic settings before. Typically for HemOnc, there isn't a lot of bone marrow transplant locums, although I've seen it before, but it's typically general hematology and general oncology. That's the need.
What is the average patient census?
I've seen people think up to 22. I think 22 is probably a bit much for if they're all iron deficiency anemia, that does not take very long, right? A follow-up for iron deficiency anemia, that doesn't take very long. A follow-up because your scan has progressed, or a new diagnosis of lung cancer, you've got to set up a PET scan, and you've got to set up a biopsy, and you've got to counsel them about whether it's something that's curable or something that's treatable or something that's not curable or treatable. You got to counsel them as to the side effects of the chemotherapy. So you can see I think the longest visit, I've actually been timing some of my visits because I am time-based. The longest visit I had, I think, was 92 minutes for a new lung cancer. But conversely, you have somebody who's had pancytopenia associated with cirrhosis for the last 3 years. Often you can just tell them that, and they'll say, "Yeah, I know. I don't know why my doctor sent me." And that's a pretty short visit right there. So it's a wide range of what you can see.
Yeah, and I know it's hard to say. It sounds like 8 to 22 will be the very wide range, right?
Right. I think that's the other thing, especially in my specialty. I never exactly know what I'm going to be walking into. So I'd say that's both a pro and a con. I think sometimes seeing a long patient list, just knowing that you have a large number of patients can be daunting, and knowing that there's no out, there's no adjusting that you're in it. This is going to happen whether you like it or not. That can be its own form of frustration. But yeah, no, my days are fairly variable depending on what's going on with the hospital, what's going on with the clinic, depending on the weather is bad, depending on how people get overbooked or not overbooked. I once worked a place where they booked 4 new patients in an hour. So they each had a 15-minute visit, and that, needless to say, there was some waiting going on there. They all showed up. So it is very variable. The good days are phenomenal, and the bad days can be very taxing. So I think having support, I know the role of APPs and residents can be, a mixed bag, but it does help to have some support to offset fluctuations in the schedule, or to make sure that someone's just seen preliminarily triage. Okay, we can deal with this now. That can be pushed off until tomorrow, because not everything is an emergency. So.
What are the typical clinical settings?
There's definitely more demand in rural areas. I have worked in urban, suburban, and rural settings. The rural settings tend to be more laid back. There's one rural site that I really gotten to know all the clinic staff, and I think it's a bit of a different feel in their clinic that has its own special feel for it. I think in places where you're covering the only doctor who's there, you have to be aware that you will probably be needed to be there the entire time that the infusion center is going. So a lot of your value to the group is just physically being there so that the chemotherapy can be given safely, right? And then I've worked in more urban setting as well. That had a fairly high volume of patients, a lot of different hospitals. It was a mixed bag. I think I'm open to whatever there is moving forward, but I do like my rural settings, I'll put it that way.
Pros and cons of locum tenens for HemOnc doctors.
Like I said, pros, I like the flexibility. I like that I have time off. When I have time off, I truly have time off. And I think that's one of the things about oncology. A lot of times you're managing the patient, you are the doctor. I was talking with another locum the other day, and she was saying the worst words in the English language are your patient, because it almost feels like in some ways it's like an inescapable burden when people get sick and they have to go to the emergency department. And should I be scared about this abdominal pain and these headaches and these fevers? And sometimes I think when the oncologist holds all of the information in their chart and it's not shared with an outside medical system, say the hospital isn't able to access the medical records, then the oncologist really does gatekeep a lot of that information. And I think in traditional oncology roles, you get called all the time for all sorts of things, people's anxiety, refilling narcotics, things that you have this very specialized body of knowledge about what has been done to the patient in terms of giving them potentially toxic chemotherapy or immunotherapy with immune-related side effects. And I think being able to walk into a system, like triage it correctly, deal with the patient's needs, and then remove yourself when you did your day's work, you helped everyone the best that you can. Being able to remove yourself completely from that ongoing of needs is helpful, especially if I have small children. I like to be able to devote all of my time to them when I'm off of work. And so I think this has been a very, good way to do that. I like being able to support other doctors who need vacations. So I try to really not bother them when they're off. I like not being bound by non-competes or really convoluted contracts. The cons are I don't always get to choose exactly when I'm going to work. So I've probably worked more weekends than I'd really like, but that happens. And then, of course, like I said, if I don't meet a business need, then maybe the relationship comes to an end. And that does happen from time to time. But for the most part, I've had really great relationships with the clients that I've had, and they've seemed to have been pleased. I've been able to come back and form long-term relationships in spite of being a contractor that's not someone who's in the business.
What are your biggest frustrations with locum tenens?
Yeah, that's a good question. Sometimes as a locums, the communication is the last to reach you. So you don't always know when there's an organizational change that, we're doing this now, or EMR is changing, or we're seeing suddenly these new patients, or you're not needed here, you're needed there. So sometimes the information can take a little bit longer to get to you than you'd like. And then working weekends, like I said, is not my favorite thing. How will I deal with it? I will cut back on my weekends. So that's it, right? So that's obviously the nice thing about locums. It's a little bit harder if you've committed yourself to 4 or 5 years of 2 weekends a month. So I think that's been nice. What other frustration? I don't know. I haven't had a ton of frustrations, to be completely honest. I think for someone who's like very fixed in their mindset of what they should be doing when they're at work, it probably is frustrating. If you can't walk in and be like, okay, here's the patient. I'm going to go see them. I'm going to go deal with this. I'll figure out how to write this in the EMR later. I'll figure out how to do that later. It probably does get frustrating. I feel like I'm flexible enough where you give me a clear list of people to see, I will go and see them. I will answer the questions to the best of my ability. I will leave a comprehensive note. I will contact whoever consulted me, assuming that's within the limits of what I'm able to do. Or I'll ask the APP or resident to reach out to the team directly and tell them these are our recommendations. And that, I think that works for me, but that might not work for everybody if they're like, I don't know where the third floor is. I don't know where the elevator is. And I don't know how to put in this order. And I don't know who consulted me. Anyway, if you don't know how to use your resources, it's probably very frustrating. I think for me, I do change. I like trying new things and going new places. So I think probably when things are not working out, I might try an arrangement with a new place, see how that goes. Maybe it will give me some insights. Maybe it won't. I do try to address my concerns directly with the people who contract me, because I think addressing things with the locums with the people, the recruiters it's been a mixed bag. I'm not really sure what reaches people on the other end. So who knows? And then I do maintain savings. So I have the freedom to cut back if I need to, if something comes up and I'm not needed for whatever reason.
Please tell us more about pay rates and compensation.
All right, so I'll say the current ranges for the last few years hourly would be around $375 an hour to about $550 an hour. I think the very lowest I've seen offered for what was termed a quote babysitting job was $2,000 for one day. And then the highest rate that I have ever heard of in one day was $7,200 in one day. It's funny because it does depend a little bit on the workload, but not always, because like I said, there's a lot of inherent variability in the specialty. And sometimes you just don't get that many consults. We're affected by all the things hospitalists are affected by. So if COVID happens, that may change the number of people who are admitted. If there's bad weather, if there's the OR is shut down and new EMRs, so people can't figure out how to put in their consults, all sorts of different things. And all of those things have actually happened to me in the last 3 years. I think pay is very loosely tied to the number of patients seen. I think in general, for an outpatient setting, they expect you to bill for between the first 8 or 9 hours. They expect to pay for that much. And I think perhaps in the future, one thing I may try to do is more capped rates, because I'm realizing that some of my clients are not able to adequately judge like how much work they're giving me. So I think giving them a capped rate will help them know, okay, if I show up, that's how much I'll make. But no, I think, like I said, I think I originally chose my personal rate by saying, okay, what was I being offered by these big locums agencies? And then adding about 20% onto that, because I've find my own travel. I found my own, lodging. I've handled my own logistics. I don't need, anyone else to handle that for me. That's how I figured out my personal situation.
Perfect. Quick question. Any difference between outpatient, inpatient? Have you noticed any difference in the rates?
I think in general, sometimes the inpatient rates are a little bit lower, but yeah, I think the inpatient rates are typically a little bit lower, but maybe not a ton lower.
Okay. And if we're talking about the nights, for example, if you're covering, if you have a separate clinic versus call
Yeah.
fees, right? We talked about the hourly pay for, let's say, clinic, but what if you take the call, maybe pager plus callback versus maybe just a flat, like any numbers you
Right.
can provide? Yeah.
So I know there's a bunch of different ways that this can be done. I think in very low volume areas, people do have, and I haven't worked in an area that's this low volume, but I know that other people they do have a 24-hour rate with extra for callback. I haven't been in that scenario. I currently do weekends. I cover hospital inpatient and all consults and all patient calls between Friday morning and Monday morning. And so there's a fixed rate for all the inpatient consults, all the overnight calls, everything that comes in from the practice, from the hospital. There's a flat rate for that. It's a mixed bag. It's the work that I'm doing right now seems to be a bit on the busier side, but I haven't had a lot of overnight calls lately, which is good. But every system is a little bit different, so it's hard to say.
Okay. And again, you don't have to mention if you don't know, but any average that you've seen for maybe flat rate for 24 hours from the weekend coverage, something you've seen or something you've experienced maybe?
Yeah, so trying to think how I would. So I get paid for 72-hour call. And yeah, I guess what I've seen and what I usually you don't get a lot for these overnights, to be quite honest. So anywhere from for 24-hour call, it might be anywhere from like 3,000 to 4,000. It's usually not considerably more.
How can HemOnc doctors negotiate higher pay rates?
I think for me, I really had to know myself and how badly do I want the work. So I think when I first started, I was willing to try a lot of things. And so their first offer was very reasonable. So I didn't really try to negotiate it much because I wasn't sure if I was going to stay there or do that very long. And I found that I was able to negotiate higher rates as I went along because I proved my worth. And that was that. I feel like there's room to negotiate up if this is going to be like a long-term relationship. For example, someone who's local to you, someone who's in a very desirable location, someone who's very desirable workload, or whatever it is about that makes them like very desirable. So I haven't tried to like spend a lot of time negotiating with people that I thought I might have long-term relationships with. Now, conversely, if you're being asked to go someplace where you really don't want to go and you don't necessarily see yourself going back again, and you have some doubts about it, then yeah, I'll ask a little bit more in that sort of situation. And so I'm not shy in that particular setting. But I think you have to know how badly do you want the work, how interesting, how was the initial offer reasonable. Like I said, I think whatever the large locums company is saying is their hourly rate plus about 20% seemed like a decent starting point, but that just depends on your area too. And you want to get quotes that are relevant to your area too, because you might get a very different rate in Montana than you do in Florida. You might get a very different rate in Pennsylvania. It just depends on where the need is. You absolutely have to know what your options are. If you don't really know what your options are, then you're just guessing. And it absolutely can change with time. Their need for you may change, and it's a flexible arrangement. I think for a group that I would enjoy working with, I would probably be more flexible in my rates. For a group that's been very inflexible and has a very hard workload and is just in a totally undesirable location, maybe not so interested.
Advice for oncologists who are new to locum tenens.
Oh, plenty of advice. So learn about taxes sooner rather than later, right? I think avoid non-competes, undercommit yourself up front. You can always take on more. It's really keep your commitments. Do keep your commitments. I have never canceled work since I started. It just makes me feel bad. So for me, I know I have to undercommit up front because I'm not going to be the kind of person who promises to do however many months and then quits. Even if you have the 30-day out, for me, the 30-day out is truly for emergencies. Like I've been like abused or hurt or something, you know what I mean? That's never happened. So I think of undercommit yourself up front, keep your commitments, remain professional, dress professionally, keep your communications professional. They can be broadcasted to the entirety of the world. Learn about business deductions, learn about retirement accounts. These are things that they don't really teach you in fellowship, and I'm getting there. I think in my first year, I definitely didn't quite understand how some of these taxes work, but I don't give out your CV willy-nilly. If you're going to do that, make sure that it's watermarked. That says whether or not if you're going to allow yourself to be presented, then that's great. Make sure that communication is very clear with whoever you're working for. Otherwise, you can watermark it with not for professional use. So it's been a learning experience overall, learning to set boundaries with people too when they communicate with you at whatever time of the day or night. Is a skill that I've learned, but overall I think it's made me a better physician, a better person. I think I've learned a lot about business from a really weird angle, but still very useful to me. I've been able to help a lot of patients, which has been fantastic. And I realized that I really actually love the work that I do. So I think with this kind of flexibility, I feel like I'll have a lot of career longevity as a hematologist, oncologist, and being able to create those connections with people. So for me, it's been phenomenal, but a big learning path, but definitely well worth it.
What would you do differently if you started again?
I think I probably would have started looking at contract work sooner instead of trying for other things that were pretty clearly poor fits at the front. I do think understanding taxes and finances is really key. I don't think we made any terrible decisions, but it really makes a big difference because bookkeeping is no small task here. Business deductions are not a small task. I probably would have wasted a little bit less time with recruiters who have absolutely no idea what's going on, trying to get information from people who really very clearly do not know what the gig involves. Oh yeah, that's a great, I'll get back to you. Okay, fine. I think, like I said, learning to set boundaries. I've done that now a few years in, but just like a polite message that says, oh, I'm not available right now. Please reach out to so-and-so, whoever's on call, or I'm not available right now. I'll be available whenever. Just really clear communication. I think having clear, direct communication probably will continue to be a challenge for me, but I think it's very important.